Yeah, I just sent it all out.
Okay, no worries. Good morning, all. We are live here in Vegas and happy to have you. I'm going to do an introduction for Mikhail Shneyder. He is the founder and chief executive officer of Nightingale Education Group, a mission-driven organizational focused on innovative healthcare workforce development across entire professional continua, from certificate programs to graduate studies to reskilling and upskilling through continuing education. From 2012 until 2023, Shneyder served as the president of Nightingale College, a higher learning institution dedicated to closing educational equity gaps and creating geographic, socioeconomic, and demographic access to the nursing profession, creating thousands of nurses throughout the United States. A visionary leader and a registered nurse for more than 25 years, Shneyder has a wealth of management experience in post-secondary education for health professions and healthcare delivery services. He is a published academic author, conference speaker, and guest lecturer specializing in strategic planning, organizational development, forecasting, and management. Shneyder holds a Master's of Business Administration degree from the University of California at Berkeley Haas School of Business. Mikhail Shneyder.
All right, thank you. Thank you, Brienne. It's good to be with you. So yay, Vegas. Hopefully, you know, what happens here today in Vegas actually doesn't stay here and it spreads all over the country. So hey, everybody out there in the cyberspace, we have, I don't know, several hundred folks dialing in, both learners and collaborators and some guests. So yay. So today, yeah, it's all about the future of nursing, the future of healthcare, really. Let's see, I probably have to turn, oh, there we go. That worked. And in order to figure out how to do the future, we have to look a little bit into the present, right? And establish some baselines and figure out where we are. So for the purposes of this, look, I blame everything on TV, all of it, right? TV is to blame, and then after TV kind of now takes the second place to social media and constant algorithms that feed people exactly what they want to hear, right? So for the purposes of this today, everybody out there, everybody in here, remove, you know, your CNN hat or your Fox News hat, whichever hat you're wearing, and put on a healthcare professional hat, a nursing hat. So we're going to be looking at everything that is happening in this nation, and we're looking obviously nationally here because we have, again, folks everywhere in the country, probably 40 some states, dialing in to this broadcast. So we're going to look at the data and we're going to figure out a couple of things. A, why we are in the place we are. That's first of all. And then what you as nurses, as the people who are entering the profession or who are continuing their journey in the profession, from any PNs here? Any LVNs, LPNs? All right, hi, awesome, fantastic. So congrats on, you know, taking the next step. What can you do from now through your, continuing your program and then for the rest of your career? What it is that you can do as nurses to change the kind of unsustainable trajectories of both the spending and poor health outcomes that we experience in the nation. So, sounds good? Okay, fantastic. So I'm going to open with this. This is directly from the National Academies of Medicine Future of Nursing Report. So this is the second Future of Nursing report that the National Academy of Medicine put out. They published it in 2021, but it's 2020 through 2030. And COVID obviously had, you know, something to do with the delay in publishing it. And this is the punchline. essentially. This is what it says. We will never thrive as a country unless we all have what we need to live a healthy life, no matter who we are or where we live. Number two, nurses are catalysts for this change. They're trusted bridge builders who collaborate with people, communities, and organizations to promote good health and well-being, no matter one's background. And three, for our country to advance health equity for all, the systems that educate, pay, employ, and enable nurses need to permanently remove practice barriers, value their contributions, prepare them to understand and tackle the social factors that affect health, and diversify the workforce. So this is a national call, and at the center of that call are nurses. The Future of Nursing report has calls to legislators, to associations, to government, to employers and so forth. But again, nurses are at the center of it. And part of us doing this, and we started this long time ago, because the mission, as you heard, of this organization is to contribute to closing health equity gaps, and through specific means. And having this workshop, and all of you out there, and having the conversation about what your role is already and what it will continue to be is really, really an important piece in making a change. Now let's talk about equity, health equity specifically. What does it mean? What is equity?
Fairness.
Fairness, okay, yeah.
Equal.
Equal. So there is actually a distinction between equal and equitable, right? So equal means same for everybody, right? That's what equality is. Like you get the same and you get the same and everybody, it's like Oprah, right? Everybody gets the same car or whatever she was giving out back in the day. So equity though, what is equity? Yes?
Getting more than the other, like you're gaining more?
Not necessarily gaining more. Equity is centered in one specific goal. Yes?
What you put into something to get a better result of what's coming.
Better result, right. So equity is really about the result, about the outcomes, right? So it is, and we want better health outcomes for everybody, as it says there. And so what equity really means, when it is truly achieved, which we are so far away in this nation, as you will see from the data, getting to that point of equity, of health equity, of outcomes that are comparable, no matter who one is, who the person is, no matter where they live, no matter which community they come from, no matter their level of income, and so forth, their health outcomes are comparable to each other. So equity really means achieving those outcomes, and every single individual needs different things, right? Needs different resources, needs different guidance, different facilitation, different stuff in order to get to a comparable outcome with everybody else, right? How are we doing on health equity in a nation?
Terrible.
Yeah, we're not that great. Look, if you're a Mikhail, good for you, right? Yay! You got it. Fantastic. There's not many of these, right, compared to the population. By the way, so you know some background. I came to this country a little over 30 years ago as a refugee, and with no money, no English, no anything. And so the fact that I'm standing before you and having this conversation is a testament to what this country is capable of, and capable of providing, and capable of doing, right? If you, and all of you, look, you're in nursing school, so I know you have the drive, right? Like you have to be resilient. You have to pursue. So it is, the possibilities really are there, right? It's how, what we do with them and how we guide people without some guidance, without some facilitation. I mean, I can tell you this much. In my mid-20s, I was hypertensive, pre-diabetic, quite a bit overweight, and yay, you know, good for me. Like this, and this is what 50 looks like today. So there is some work that goes into it. Now, I really had really good guidance around this mentorship and coaching and all of this stuff that came along the way and helped me get there. You are those mentors and those guides and those coaches and to guide the population toward it. Before you can do that, though, guess what? You have to try doing it yourself. And as Yoda says, try not. Do or do not. There is no try. This is exactly applicable to nursing school as well. Try not, do or do not. There is no try, right? Just look at Luke Skywalker. All right, so for those of you who, you know, Star Wars fans. And another big thing, and why I am so set in this mission, and kind of it's a personal mission, and then now it's an organizational mission, driving health equity through opening access to one of the best socioeconomic mobility vehicles that we have in this nation, which is the profession of nursing. The profession of nursing really can take somebody from low income after they get licensed firmly into the middle and upper middle class in this nation. There's not much more than can do that. So try not. Go for it. Do it. And that's what nursing offered me as well, right? It offered me a way out. It offered me a way into a better life, and therefore, really would like to share that. So anything else, any questions on this? See how there's employ, educate. This is just the educate part of it. Compensate, value contributions, all of that. Guess whose job is going to be to do that? To push that forward. You guys, absolutely, yes. You will have to do it. Starting now, starting today. You're not powerless already. And armed with this information from today, guess what? Woo! You'll be good. By the way, everybody, we will have breaks. Yay. 1. So we'll go for about an hour, and then from now, and we'll break, and then we'll come back and finish it up. All right, so let's dive in. And those of you in the cyberspace, I have to tell you this. You probably have noticed we're taking attendance. Yay! So you probably have noticed the links that are pinned like right to the top of the chat. And those are, and you will get questions throughout throughout this broadcast. And the link will be posted. You click on the link or copy the link and into another browser or whatever, and then you know, it's some of it multiple choice, some of it you have to think a little more. So just answer the questions. We're not grading the questions themselves. It is really only for the attendance purposes. You guys don't have to do that. Good for you. So question 1, everybody. Question 1. Ooh, come here. Right there. Right there. Come on in. Yes, please. Question 1. And this is for all of you as well. So they're going to be answering it there. You are going to be answering it here. Why is health important? It's a loaded question. Yeah, I agree. Like, why is health important? And this is where the interactive part starts. Like for real?
Health, and what's the quality of health?
Well, health, yeah. Think of health as overall well-being, right? Wellness. So overall sort of, and you're right, it's multidimensional. But think of it that way. Yes, please.
I guess when I think of health, I think of how you feel when you're healthy and
Yeah.
your energy. You have.
Very
I have
good.
an 8-year-old, so I'm able to do more with her when I'm feeling better, when I'm healthier and I'm not tired and
Yeah.
I'm overweight. And, I've lost weight, so it makes it easier to do things with her. So the health
Exactly.
really plays
It's
a
the
factor in
quality.
your life.
Yeah, quality of life really improves, right? When somebody is well. You had something else.
I was just going to say that goes hand in hand with quantity as well, because depending on how you are in your health, can dictate how long you live.
Say it again.
I said, depending on the quality and quantity actually go together, because
Quality and quantity.
right, because
Yeah.
if you're going to not be very healthy, you might not have as long a life.
Correct. So longevity. By quantity, we mean longevity. Yes. So healthier life means longer life. Now, I don't think any of you are like, yeah, I'm ready to go. Right? Okay. So which me neither. Therefore, it remains true. So longevity comes with the quality, energy, all of this stuff. So on the individual level and the family level, it is absolutely essential, right? And because it is essential on individual and family level, then it comes expanding out. It's like ripples out for the community well-being, community health, and so forth. So it's basic, fundamental human need. That's what it is, right? Fundamentally. Oh, by the way, you don't need to take pictures of this. We will send you a PDF copy of the slides afterwards. So this second point there, though, is very important. Better health on a community level or a national level directly correlates to the economic health and economic prosperity of that community. Everybody with me? So there is a direct correlation. The better the individual health is within a community, the better economically that community will be doing. So and again, health and wellness, multidimensional, right? Let's talk about that. So what kind of wellness do we know? Mental, right? So there is this mental wellness. What else? Anybody? Physical? Yeah. I mean, when people think of health, and when we broadly think of health, physical is all we usually think about. It is much more complex than that. So physical, mental, what else? Wellness. Social wellness, absolutely. And social media that bills itself as wellness is not. That's not well, that's not social. I don't know why it's called social. It's the antisocial media. We'll talk about that later. Yeah, so social, what else? Come on, think about it.
Socioeconomical.
Right, so financial. Financial is a part of wellness, right? And many of you probably understand, I certainly understand it really, really well. Because, for the longest time, and this is back in the 90s, but 2 Whoppers for $2 from Burger King, that was my daily diet. And a little fries on the side. Woo! No wonder hypertensive, pre-diabetic. But it's cheap. It's cheap. So the hunger was satisfied. Was it nutritious at all? Not at all. And so because I lived essentially in poverty because I didn't have the means, the resources to be able to afford better food, that's what I ended up with. So very important. Financial is very important. What else? There's another couple of things. Okay, so I'll give you this. There's occupational wellness, right? It has to do with both the job that you have and connecting with that job, having a passion for that job. Lucky for you, I'm pretty sure all of y'all have passion for this, what you signed up to do, and especially those who've been around for a while in the profession. So yeah, passion is important, but then the how safe you are, right, occupationally. How safe are we in nursing occupationally right now? Like financial is all right, occupational for nurses.
No.
No?
No.
RNs, no?
No.
Financially don't do well?
They do better than the average.
Yeah, I mean-
But if you look at what's going on in the economy right now,
Yeah.
it sucks.
I understand, and we're not here to discuss the current economy. We're here to talk about nursing, and as I mentioned, it is one of the best socioeconomic mobility vehicles we have in the nation, right? So it is not like, look, there is, if your goal is the top 1%, you're probably not in the right space. But if your goal to firmly to be in that upper middle class and kind of afford the things, have your American dream with the house and whatever else it comes with, fantastic, then it works. But back to occupational and the safety, occupational safety, it is not quite there. Why? Being around and treating, yeah, we precautions, they're there and all of this. If you follow those universal precautions and things like that, you are very unlikely, unless it was COVID and nobody knew what it was and so forth, very unlikely to, there's protection for you, certainly from that respect. Yes?
Patient safety, where if a nurse makes a mistake and...
Right, so that's a different, making errors, right? And there is that, please.
What about technology? A
So-
lot of times I'm seeing in hospital settings, they're coming in with like robots, with a virtual.
Yeah, look, technology is going to be your best friend, right? Because instead of keeping everything up here, there is something that is much more has much more information and can synthesize. I mean, the tools are not quite there yet, all of the AI tools and so forth, but it really is going to be an assistive thing and will be a protective thing for you, because there's a highly publicized case a few years ago where a nurse working her second shift, so she was like on 16 hours at this point or something like that, and she went to administer medication, and the technology was, and it's a Pixis machine or something like that, and they were switching over, right, exactly, and so she went to get the medication out of the tech box, and the tech box asked over and over and over and over again, are you sure this is the right medication? And she said, yes. Are you sure this is the right medication? Yes. Are you sure? And finally dispensed it. Patient died within seconds. It was a wrong medication that sounded very similar in it. So, and this is a piece of it. We're so erroneously trained to rely on our brains. Your brain is not reliable. I mean, for real. You can learn, you can be very, very good. Double checking yourself constantly goes a long way, right? And as you look at this technology assistance. So I would say when it happens, start embracing it. There's a lot of technology that we use here, right? We allow you to use calculators. Duh. Why was it ever not allowed? A thing that actually, can do the thing, add things and divide things, way better than you can do on paper, right? All of us nurse geniuses. Anyway, so that's that. The occupational, but the safety is not there. Here's a couple of things. Just social drives it. because we're so polarized and we're so intolerant and we take it out on absolutely anybody. And patients take out they're already in a kind of tough spot because they're not feeling well or whatever is going on with them. So there's quite a bit of that's happening. Now, in this profession, whether you know it or not, we have some pretty intense nurse-on-nurse, I'll call it violence, right? Whether it's verbal or whatever it is, that exists, that is going to be yours to change. And then the biggest thing of it all, because that's where it stems from, shortage. We do not have enough practitioners, we do not have enough providers. And everybody is understaffed. Everybody. And so the only way to start improving and building all those things is to improve the supply side of nursing. So that think about that. Anyway, so there's other wellness dimensions that you'll learn about as you go. You had something? Okay, all right. Sorry, I preempted you. Okay, and so more energy, healthier, more effective, just more effective, which then feeds into economic and so forth. Yes?
Looking at the angle of policy, development, legislation coming into place, talking about safety.
Legislation around safety?
Yeah, anything else, I don't know.
Yeah, I don't know. It's very difficult. Look, it's very difficult to legislate. It's very difficult in the current political environment. Essentially, legislating anything, it's.
Even within the nursing profession, like we have the now, right?
Look, again, I think if we address the supply side of nursing, if more nurses are actually, and I'm not going to go into a big spiel here, but the current system, the way it exists, the current nursing educational system can produce way more nurses than it actually is producing. So legislation around that, holding schools accountable, not whether or not they pass a licensing exam on the first attempt, but rather how many people that you enrolled actually you facilitated to graduation, actually make it there and then make it to licensure no matter which attempt it is, right? So that would make way better sense than holding schools accountable to something that doesn't really matter and has no evidence behind it. For a profession that is so evidence-based, our regulations are far from it, especially in education. So that's something to remember. All right, now, so how we doing? How we're doing financially in healthcare? Let's look at some data. Why don't we?
If you're an immigrant that have no education and have no health insurance, you do good because we can't place you. You're stuck in the hospital.
Well, again, there's coverage and coverage issues. We'll look about again, and we'll talk about advocacy, right? Because just complaining about something, just being mad at something, change, and waiting for a miracle to happen. We've been waiting for miracles for a very, very, very long time. How many nurses are in the United States? Anybody? A lot. A lot about describes it. Wild guess.
50,000.
Oh gosh, way more than that.
200,000.
Way more than that.
500.
Way more than that.
100.
Oh, okay, till we get there. There are about 4.5 million nurses, and we're still short. Now, 4.5 million accounts to more than 1% of the US population, meaning a nurse for every about other 99 people, less, a little less. You would think would be the healthiest nation on earth.
Or county RNs or?
This is counting. This is almost exclusively the number that I'm reciting. And again, new data comes out every day. The number that I'm reciting is almost all exclusively RN. If you add PNs into it, we're close to 5 million. So, yes.
Do you think that COVID played a part in the shortage, or is it education more so? I have had the experience of a school that isn't an advocate for their nursing students.
Yeah.
So I know that is actually taking place.
Multitude, yeah.
I wanted to know whether or not is this the burnout from COVID that's creating this.
COVID played a role, a big role, right? There's all sorts of stuff happens on the early supply side. There's there's this data that says that something like more than 50%, 60, I don't remember the exact number, leave their first place of employment in a very, very short time, and some folks do not go back, right? So they're educated as nurses because it is tough. The job is tough. You have to be resilient, you have to push through it, you have to train, and this is what we do. And on the school side, we're preparing, the vast majority of the system is preparing students to pass an exam on the first attempt, rather than actually practice and face the realities of the practice settings and so forth as they exist now. So people are underprepared, and obviously not here. So yes, Brianne. Brianne has a question from the side of the space.
Does your number of nurses count for the nurses who have retired but still have an active license?
Correct. So this is actively licensed. This is actively licensed. By all measures, mid 80% are like of that number practicing at the same time. But whether, that's not the point that I was making. Whether you're retired or not, somehow, if you're licensed, you do not stop being a nurse, and you do not relieve the responsibility for making things better and changing the system and driving it forward. Like run for Congress if you're retired. There's plenty of retirees there, like do something. So whether or not somebody is actively practicing, that shouldn't matter. Yes?
Nursing school also, well, medicine in general, getting an education towards that also has a stigma or a visage of like being too difficult for like laymen or average people. And I feel like the idea of it in general acts as a filtration system that weeds out all people who don't feel like they have.
Right. It's a myth.
To be able to do it. Yeah, it's a myth. Like,
it's a myth. Inability to do it or some special person is needed is a myth. Absolute myth that is created through, again, but if you think about it, and I'm like, this is the last thing I'm going to say on this subject because we're kind of veering off, but as you think about it, if the system is designed with the only outcome in mind of graduates passing a standardized exam on the first attempt, what do you expect, right? You're not good enough, you're not good enough, you're not good test taker, bye. You come from lower income, didn't go into good secondary school, high school, goodbye. We don't want you. That's what's been created. We're actively trying to break that cycle in this country. This organization, Nightingale Education Group. I go around, I meet with politicians, I meet with labor departments, I meet with governor's offices and so forth. By the way, I met with the Governor's Office of Economic Development here in Nevada, and we educate decision makers, we educate policymakers on what actually is saliently important and what is not, and what has evidence behind it and what doesn't. So you're absolutely right. It's this idea, the profession to this day, speaking of kind of holding people out and convincing people that it's not for them or however else, or not admitting them or not graduating them. The profession is still largely female. Everybody gets that? Yeah. High 80% are female. There's only 12, it depends what count you look, 12, 15 maybe, males in the profession. And close to 80% a white female. Now, in order for this health equity, there's multiple studies that say the profession has to start mirroring, that's why the call for the diversification on the previous page, the profession has to start mirroring the populations that it serves in order to get to better outcomes, in order to get to health equity. Culture is such a thing that you have to live it. You can't necessarily teach it to somebody, right? If somebody hasn't lived in poverty, guess what? They will have no idea. They'll have their book knowledge, and I'm like, oh, go do that, dear. To me, in my mid-20s, you just have to eat better. Sure. And what, pray tell, I can afford outside of $2 for 2 Whoppers, right? Yeah. So that's, and somebody who understands that can come in with better solutions, better guidance, better facilitation, and all of this. This is why, I mean, this demographic and socioeconomic mirroring is needed in order to improve the outcomes, actual health outcomes that we have. Now, I'll give you another example. The number 2 preventable cause of death. Anybody wants to guess? In the United States. Not obesity. Obesity leads to number 1 cause of death. Not diabetes, not quite there. No.
That's hypertension.
No. So well, you're right. Hypertension and all heart-related disease is number 1, fully preventable. Vast majority of it. Number 2 is colon cancer. That is the one cancer that is completely and fully preventable. You just have to, put a scope up there as recommended. Or do Cologuard nowadays or things like that if you don't have family history or stuff. Guess who dies disproportionately more from colon cancer than any other demographic group? Demographic group.
Whites.
Yes.
African American men.
Yes, absolutely. Black men die from colon cancer more as compared to proportionally to the size of the population than anybody else. Why? They don't want to be touched. Why? There's a stigma around that, yes, having a colonoscopy and all. Why? No trust. No trust exists, and this has been very well documented. Hence, again, the mirroring of having more black males in the profession can start bending that outcome and creating an equitable outcome for that demographic group. See how things are connected?
Yes.
All right, fantastic. Like, wheels are turning. So, yeah. So, do. Try not. Do. Okay, so to my question now, everybody in cyberspace. Oh, no, not yet. Come on. Why is this thing? Why am I not? Okay. I'm just going to do that. So this is U.S. healthcare system performance as compared to the rest of the developed world. Congratulations, we're winning. Not really. As a matter of fact, see, like, da-da-da-da-da-da-da, and then poof, precipitous drop in performance score. That's us. That's and we spend absolutely the most. This is 2019 data. See us? That's the line up there. The rest of the developed world kind of clusters around here as compared to the entire economy. We're winning. I'll show you this one. Yeah, and so I have a question. And those in cyberspace, don't take this number because that number is from 2019. And there's better data out there and newer data from 2022, which I'll show you in a bit. But the question for the cyberspace is this. What is the US spending on healthcare per capita, per person, every year? So the question is going in. They have multiple choice. I'll ask you this like in a minute. This is performance compared to spending.
But also,
Yes.
these countries come here too.
What do you mean some of these countries come here?
Like Canada, I heard a lot of people come to the U.S.
Well, the fact that you heard something doesn't make it true, right? If you do have evidence to support that, actual empirical evidence, studies that suggest that that is true, that would be nice. Canada has a socialized healthcare system, which, by the way, again, gets way better outcomes than us compared to the spending that it does. So all of this, and when I'm saying remove the hats, that applies to Facebook, Twitter, Insta, whatever else, wherever else you're getting your information. The only reliable information out there is actually from peer-reviewed studies. Everything else is noise, distraction. So you might have heard this. I may have heard that many Americans go to Canada to, I don't know. No, I'm not saying that that happens. But it's an important to understand from here on out for the rest of your learning career, which hopefully is lifelong, that information that is reliable comes from only a handful of sources, right? There's some journalistic stuff, although journalistic integrity has been lost as well across the board a lot of times. So peer-reviewed stuff, journals is like your best bet on figuring out whether something is true or not, and something has evidence behind it or not. So that's the comparative performance. Meaning we spend the most, and again, our outcomes comparatively are the worst. Everybody else is a cluster, right, out there. And those are the countries that are Western, industrialized world. Okay, so this is how we do an affordability of care. Equity, cost-related problem affecting low income, 50%. 50% of low income population and 20%, 27% of actually high income population are affected. Everybody else? Yeah. So, winning indeed, just not in the right direction. Avoidable mortality. Life expectancy. We talked about longevity. Suicides. This is multiple chronic conditions. 29% of the US population has multiple chronic conditions. Multiple. That's almost a third of everybody who is in the US. Over 40% have at least one. Close to half of our population is dealing with chronic conditions. Yet, many nursing students watch Grey's Anatomy or the like, and are like, oh, I'll be with McDreamy in the ICU. That's nice. You know where you need it? Actually, the biggest need, according to this, is chronic diseases management. Because what ends up in the hospital nowadays? Chronic diseases that are acute exacerbations of chronic conditions, mismanaged chronic conditions. Even if there's 3.8 million working nurses, right? We don't have time. We don't have time because we're constantly in this reactive state, catching up and catching up and catching up. It is unsustainable. It has never been sustainable. But we've decided that that's the way we're going to approach it. So NICU, probably not. There's plenty for the NICU. And they're like, well, that's not about me. Yes, yes, yes. Complex chronic disease management that prevents hospitalizations. Because by the time somebody is in the hospital, it is costing the system, it is costing all of us, the taxpayers, a lot of money, and individuals as well, and families and communities. And so that's yeah, think about that. How do you like that one? I'll give you. So that number is a little outdated. The latest data is 42% are considered severely overweight, and it ranges from 33% in Washington D.C., so District of Columbia has the least, to 51% in West Virginia. Do you know how Nevada fares? Where's my Nevada? 41.4. Right in the middle there, right in the center, a little below average. So not too bad. Anybody from California? Okay, yeah, so I figured. California, 37.6. Not bad, comparatively. Still, close to 40% of the population. And that leads to what? It leads to, number one, preventable cause of death, heart disease of all sorts of iterations. Hypertension, arthritis, stroke, cardiovascular disease, coronary heart disease, heart attacks, diabetes, high cholesterol, and kidney disease. Yes?
Okay. I don't want to bring up the point of the vast minority of the population falling into the realm of just being too heavy for their height, for like how we classify obesity. More so I want to focus on how does the potential problem of having heart diseases or other potential diseases play into someone like this?
That is absolutely correct. Weight on its own would not be anything unless the evidence is conclusive that overweight leads to and contributes to, it's a causality to all those other things that I just mentioned. So again, and it is, according to the data, according to the studies, it is virtually impossible to avoid one of these things later in life when somebody is overweight. I mean, it's a proven causality. So I understand, look, I'm not here to shame anybody with body image or anything like that. Absolutely not. Again, removing all of the other hats from managing of health and wellness, if somebody inevitably will arrive at multiple chronic conditions that are unmanaged, it's just that. Again, we never bend the unsustainable paths if we make ourselves feel good. Because we're in that practice of making ourselves feel good somehow. And sort of disregarding the actual evidence. And if anything you carry out of this today, evidence, 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 evidence. Nursing is an evidence-based practice, not an opinion-based practice. Not a feel-good-based practice. It's an evidence-based practice. Physician visits. So Germany is not Germany, New Zealand. So visits per capita, 2.7. We're not the highest. Switzerland and New Zealand are lower. Why are they lower? Why Switzerland and New Zealand has less visits than us?
Because they're healthier?
Yeah, because they're healthier. They're a healthier population. We have low number of visits because we're understaffed, we're underinsured, we're under all of that stuff. And we're overly optimistic about our chances. Oh yeah, no, the scary picture on the pack. That's not me. Oh, and this peach. Ooh. Enter the dragon. Yeah. It's like, oh, yum, yum. Tastes so good. That scary stuff is not going to happen to me. Like heart disease and other things. It will. That's the point. And the data proves it. All right. So here's how we're doing. And that's you can read it yourselves. Across the board, our system performs the worst. And yet, we spend the most. In 2022, $4.5 trillion. Trillion. So you know how to think about it? You can, like, those of you with paper, like, start writing it out. So like $1,000 we understand, right? Yay. Then you take another, like, 1,000 thousandths, right? What do you get to? Add 3 million, add 3 zeros. You get to 1 million. Yeah? And it's like, ooh, 1 million. If I have 1 million for retirement, I'll be, wow. Like we get how much money that is, right? Multiply that by another 1,000. You get to $1 billion. Multiply that by another 1,000, you get to $1 trillion. Then multiply that by 4.5. Ta-da! It is an inordinate amount of money. Inordinate. And if we at least were getting the outcomes equitable with the rest of the developed world, I'd say fine, let's spend it. It'll be justifiable. The outcomes that we actually get do not justify this level of spend. We spend almost $13,000 in almost $13,500 in 2022 per capita. Means per every person that is actually counted in the census. Yes?
With all of this information, people are living longer, but they're much sicker.
Correct.
I work in the med-surg, and we have patients that are 99, 100 years old, but they're like definitely sick almost.
Right. Again, people do live longer, but not as long as in other countries.
They are.
Right. And again, and longevity, having longevity without health, that's and again, and it's cost. As a matter of fact, the most expensive period of life, of care, is like last couple of weeks of life, when we go through extraordinary measures to keep somebody who is very old and very sick alive for just a little longer. My own family went through that with my grandmother to my protest. Put a feeding tube into her. She was refusing to eat. So no respecting, she couldn't talk, but no respecting the wishes. Her wishes. And she was kept alive for, and suffered for a bit longer. So again, and it's very, very expensive at the end of life. Yes.
With that number, is that including like the actual hospital costs where they're overcharged for $200?
This is the entire, we'll look at the spend here in a second. This is the entire spending in the, so $4.5 trillion, which is almost a little over 17% of our entire economy. So everything that is produced in the economy, milk, cars, whatever, educational services, 17%. Is healthcare. This is higher than anywhere else by far in the world. And does everybody have access? No. So per user cost, actually those who have access to it is way higher than that. Right? This is just average per capita. So healthcare growth significantly outpaces economic growth. You know how there is a talk of recession recently, we avoided it, looks like, soft landing, all of that. You hear all of that stuff. Guess what didn't stop expanding? Healthcare. And we're well and alive outpacing on average, the growth is about, and has been over the past decade and a half, at about 8% per year. Did the economy grow 8% per year? Nope. If it did, whoa, it would be so good for everybody. Nope, it didn't. So that's something to remember. Okay, other questions before we move on to figuring out who actually pays. So Bree, would you put the next one, which is, how much do government entities spend on healthcare? Government entities, meaning federal and state government. Okay, I'll help. Who pays for healthcare? This is the payors. Medicare is the largest single payor in the nation. Medicaid, all states combined, up there as well. Private insurance combined, 1.3 trillion. And then out of pocket is over $470 billion. That's in addition to what everybody else pays. So what I want to point your attention to is 13,500 per enrollee in Medicare, and 6,000, less than half, in private insurance. Why? The what? No. Actually, Medicare per service pays the least because they have negotiating power. Why? Who does Medicare insure?
The older.
Yeah, and folks with terminal chronic conditions. Like the end-stage renal disease after one has had it for 36 months or so. That's what that gets insured. Whom private insurance insures. Mostly. Well, the rich. I mean, like you probably all have some kind of insurance, right? Through likely private. So it insures younger folks, more able folks, healthier folks. Back to the example of 99-year-old that is on a deathbed and is being, and who's paying for that? Medicare is paying for that. Now, tell me any other insurance. Take a car insurance, for example. Is there any car insurance company out there that says, okay, I will absolutely for sure insure you if you're for sure to get into an accident, often. And I'm not going to insure anybody else. That would be insane. So, is it? Is this any less insane? What is the one major difference between our healthcare system and that of the other countries on that list?
Everyone gets it.
Universal. That is correct.
And since it's like universal, they don't go to the doctor for the medications per se.
There's all sorts of, like on the delivery side, there's all sorts of things that different countries have different delivery mechanisms. Some are government-owned, some are not. But universal coverage and single payer. Meaning risk pooling happens. They insure sicker people, they insure healthy people, everybody's in it together, everybody pays for it, and then everybody gets access to care as needed to produce the outcomes that they actually have. Yeah? Again, we can argue all from anecdotal evidence or somebody said this. Oh, in the UK, it takes them so long to wait for a doctor visit. Yet, the outcomes are way better. So it is really, I mean, think about it. I'll show you some waste numbers later and to further illustrate this point. Universal coverage. And what do we have here in this country? Psh, I'm 20-something, I'm like young and, fit and all of this. Ugh, why would I pay? Because guess what? You will be old. Universe permitting. Yeah? And then imagine everybody's like, well, screw you. You're old. And that's again, we make everything into a political argument rather than actually thinking as a community. What if we start thinking as a community? And from the health equity standpoint, and from all of those other things. Then some of those arguments that you hear out there will not be at play. And unfortunately, we don't think that way. Unfortunately, it's me and mine, that's all that matters. So, okay. I'll show you another couple of things. So federal government, households, private businesses. Households already pay 28%. Through premiums, through deductibles. Yeah, everybody with me? Where do the dollars go? $1.4 trillion. Acute care. What did we say about acute care? The vast majority of what happens there is unmanaged, exacerbated chronic conditions. So this complex chronic condition, chronic disease management is really, really important for us to do as nurses. And again, drugs. Yay! 400 billion. It's like my mom has the sniffles, goes to the doctor, and then demands. No, I know what I need. And the doctor has what, like 30 seconds to spend with her? And it's like, whatever, here, go. Yeah, rather than, patience, fluids, rest, virus, like antibiotics are not going to help. And yet, she's not alone. You know, because everybody watches TV. It wants to twirl in the hills, just like she does. Just take this. And then the really rapid, you know, you probably will die from diarrhea. Disclaimers. Yeah, I'll show you again. I'll show you the waste on this. Waste estimates in our system. As much as close to $1 trillion a year, $1 trillion a year is wasted on those things. Failure of care delivery. There is no coordination among providers for the most part. So there are constant failures along the way in that because there is no coordination that really, really, truly happens, right? There's no concierging people around, right? I mean, like, again, you should my parents is a good example. I mean, they're at the doctor's weekly. Oh, and now this. And the doctor goes, well, dear, you just have to lose some weight. And my mom stamps her foot and says, you should look at yourself. Which she has a point. Right? Because do as I say and not as I do is not that effective. Don't do it, darling. You will grow up mommy bad. This one, from the age of 15 to 27. Because they don't do it, didn't help from my mom. It's like, oh, it's cool. She enjoys it. I will too. Failure of care coordination, care delivery, overtreatment, overprescribing, all of that is there. Pricing failure, fraud and abuse, and administrative complexity. Administrative complexity of coordinating all of the providers with all of the payors, costing us additional $300 billion per year. So you tell me what solutions we can have. Okay, and we're going to look at this one, and then one more, and then I'll let you go on a break. So, and maybe we'll just go through this and then do a break. So factors affecting poor health outcomes. Let's walk through them. That first one, tell me more about that. Why?
Because when you come from poverty, it's hard to step out of it.
Right. So intergenerational poverty is cyclical. It just happens and happens and happens and happens. Generation after generation after generation after generation after generation, which then prevents access generation after generation after generation, which prevents better outcomes generation after generation after generation. And breaking intergenerational poverty cycles, that's really, really tough. That is really tough. And so poverty has a lot to do with it. Look, I can access whatever care I want anytime I need it. I'm one of the very few lucky ones. So think about that. Social isolation and loneliness. Despite social media, I'll give you a couple of figures here. Oops. Living in isolation. Now, by the way, when people think they're not isolated because, you know, they have so many friends on Facebook, look at me, look at my food. Living in isolation reduces our chances of survival, and social isolation increases the risk for premature mortality by 29%. Poor social relationships, social isolation, and loneliness can increase your risk of heart disease by 29% and risk of stroke by 32%. Smaller social network size, again, like real 3D people, not like imaginary Facebook friends. Smaller social network size is associated with an increased risk of type 2 diabetes and other diabetic complications, including heart attacks, kidney risk. Among older adults, chronic loneliness and social isolation can increase the risk of developing dementia by 50%. Being more socially connected can improve stress responses and minimize the negative health effects of stress. Social isolation, or even the perception of isolation, can increase inflammation in the body to the same degree as physical inactivity. Loneliness and poor social support have been found to significantly contribute to the development and severity of illnesses after exposure to viruses. Boom! Take that, you know, the social media giants. Yeah, and it contributes. So social media actually contributes to that fact. Right, constant scrolling, constant looking at the highlights, coming to you in a sec, constant looking at the highlights of somebody else's life, and then comparing. And then what you see is not actual life. Here's my food, look how pretty. Well, that's nice. Yes?
I fully understand the mental health complications, but how does isolation directly correlate?
You tell me! That's a great question, and I was going to go there, but like, you tell me. How do you think social isolation creates all of this other stuff? Heart conditions, inflammation, all of that.
Depression, anxiety.
Yeah.
Right, so that sets in, and what happens? Eat your feelings, exactly. Move even less. Don't get out of the house. No fresh air. On and on and on and on. All those things that we actually physiologically must have in order to thrive and flourish. Basic physiologic needs, remember? Yeah, food, nutrition, as a matter of fact. Movement. Yeah, air, things like that. So it is. They're interconnected. It's not a direct cause, right? It's a correlated causality, because one thing lead to the next thing, lead to the next thing, lead to the next thing. If you live in a constant, which a lot of young population does live in constant state of comparison to something else, to somebody else, to, you know, like who else is doing well in the beehive? And why I'm not doing that well? And why is Beyonce is not my friend? No, she is my friend. She is. Anyway, I mean, that's it all contributive. It affects psyche. As a matter of fact, suicides among young population are at an incredible rise. Because what social media shows you is simply unattainable as life. Nobody has that life, not even this guy. So let's, you know, and climate change, tell me more about that. Hotter, yes. What else? With the climate change, what happens? Yes.
I think it affects how we go about our daily living. So like, if it's too hot outside, then you don't want to go outside, be active.
Absolutely. So heat is one thing. There are other things that happen. Yes.
Rising sea levels.
Rising sea levels, right, and warming oceans. What does that do? More moisture in the air. Winds that are destructive, that bring these hurricanes now at a rate that is incredible down south in this country, southeast, right? Every year, and now northeast as well. Every year. These tornadoes that constantly spin out more than So why is this a health issue? Why is climate? Why did the National Academy of Medicine pronounce climate change as one of the greatest health issues of our time?
Because when disaster strikes, you go get the perishable foods. The perishable foods cause the heart.
So there's, yeah, I mean, it's a very complex thing. It affects, it displaces people. It affects daily lives. It does all sorts of things. And the American Nurses Association came out with a statement just recently as well, saying that calling nurses to start addressing not only effects of the climate change, but the cause. Because again, it's impossible. If it continues on the trajectory that we are, it is really bad for health. Hurricanes are really bad for your health. Yeah. Or tornado, especially when it kills you. Same with guns. Gun violence is a health issue. Number one cause of death, number one, among people 1 to 19 years old. Gun violence, number one. And I'll give you another piece of data on this. Lost it. All right, I'll come back to that. So, and why? So why is it a health issue and not a political issue?
Because it's mental health.
Well, mental health, yes. So by the way, as the evidence shows that more people die, more deaths from guns occur by suicide rather than homicide. And number one. Why else? Why is it a health issue? So that's deaths. Let's think about other things.
Shootings.
Well, accidental. What else happens with guns outside of death? Injury. 30,000 inpatient hospital stays, 50,000 emergency room visits, and more than $1 billion in immediate medical costs. More than half of all adults in the United States have been directly impacted by gun violence, meaning they or a family member were threatened or hurt by a gun, or they witnessed someone being injured by one. And when you witness something like that, yep, and then it rolls and rolls and rolls and rolls and rolls. So again, what I'm trying to convey to you is that A, throw away your TV and like unsubscribe from all social media, and search for evidence elsewhere, and start thinking as a nurse whose promise it is better health in the communities, whose promise it is to deliver better every wellness and all of this. And why it's important, we've talked about that. So without nurses getting involved, and we'll talk about how a little later, it is only going to become worse. It is not changing. So, and on that note, 15 minutes, everybody. 15-minute break, enjoy out there, go stretch. I suggest everybody here gets up and out there too. Maybe you can step outside and take a breath of air. Before we continue, so far, all of this that we've discussed, questions, comments, wishes?
I like how you're still intact about what's going on in today's society, even though you're on the political side of it now.
Okay, so what's going on, but not in a political way. Look, health is apolitical. It shouldn't be. Health itself is not something that should be politicized. And yet we do a really great job in this nation of doing just that, of politicizing it. Health is a fundamental need. And again, if you ever have to remember that, refer to that. There's many studies out of Western Europe starting like in the 1990s, that directly correlate population health to the economic flourishment, economic prosperity. So it should be, right? Because at the end of the day, the healthier the population, the better it is for everybody, for all participants in the economy, for all residents of a nation. It is just better. And yet again, we have completely put it on its head and twisted it. And we make everything into a political issue rather than asking, is this truly about health at the end of the day? The basic need that all of us have. And again, if we started, this is all about framing, right? I've asked you, start framing things from the viewpoint of a community, not necessarily, constantly yourself. Because ourselves, look, we're a product of our, system, and what we know is what we know, and as a matter of fact, this is one of the latest studies out of Stanford that essentially says they question the existence of free will and free choice and agency, essentially, on an individual level. And so what it shows is that we are captive. And the way we act and the way we show up and the way we behave is captive to, it's kind of the product of our development, the product of our egos. And then everything that continually feeds it. And so we don't make decisions that would remove kind of ourselves from it, and we don't show up. When that is figured out in humanity, right? We're going to have a much better world. When we figure out how to show up with each other as human beings and empathize with each other and support each other and realize that all of us, the entire humanity, but let alone people in this country, we're here together. And at the end of the day, it is not like the survival of the fittest any longer. It is really about the flourishment of the community. Right? And yet we're still driven by very, kind of baked in, some of it is purely physiological and like eons of brain programming that exists. Amygdala, right? Ever heard of that one? Ooh, that's a fun part of the brain. Like that's where the dragon is. It's like anything and everything. Or it's fight or flight, right? Or like, it's not happening. It's just not happening. If I ignore it, it's not happening. It's happening. All of this happening. Let's talk more about, tell me on those, on the first four, and just your thoughts, what can you do? You, individually, what can you do? Yes. Educate, absolutely. Number one thing that we have actually as nurses, that's the power. We are trusted at the end of the day, right? Gallup polls constantly say it's the most trusted and respected profession. Use that power to educate, again, not based on opinion, but to educate based on evidence. Very good. And whom can you educate? Right, but one at a time. Everyone, right? Everyone is kind of yes, everyone, but specific, yes. You can educate the community, right? Getting engaged and involved in your community, either like Department of Health level or county health or whatever it may be. That helps, right? You know people. I mean, start with your Facebook friends. I don't know. Look, there's community there. Use it for good. Use it to do something that actually matters and can make a difference. But who else? Who else, you as nurses, whom else can you educate? Yes?
Your family.
Family, absolutely. So kind of applying this stuff to yourself, I think, first and foremost is important, right? Just remember, constantly recall my mother. And then you can, it's like, oh yeah, don't do like Mikhail's mother does. Like, actually, be a model. Yes?
Our peers.
Peers, right. Exactly. You all will be in the organizations, right? Or already are working somewhere. There is audience. There is an audience for that education there. What else? Who else?
Sick.
The what?
Sick.
The sick. Certainly, the population that you work with, right, in your capacity. Anybody in unlicensed assistive capacities right now? Like CNA or things like that? Yeah, several of you. So it's absolutely. So you are with patients. You are with people. And who else?
Family members?
Family members, yeah, we had that. Go ahead. Yeah. Yes.
Church members.
Church members, yes. Those are organizations that actually, and people have camaraderie and people have connection in those organizations. Absolutely. So yes, if you're a member of a church, that's a community. Eventually, politicians. Eventually, people who are in government, who sometimes don't know what the evidence out there is, right? And though, I can tell you this much. In order to actually be effective at this education, you have to know your stuff. And you have to know your stuff, as I said, not from somebody's opinion, not from a talking head, which is there's so many on TV. News is entertainment. That's what it is. Targeted entertainment. Stop with targeted entertainment. News is about making money at the end of the day. Whether it's the talking heads making money themselves or the networks that put them on. News is very rarely evidentiary. The vast majority of what happens out there is opinion-based. And then we regulate by opinion. And then we legislate by opinion. Wouldn't it be great to have half a Congress nurses? Fantastic. We would get a lot done. Where are we? Not a single member of Congress is a nurse. There's some docs, lawyers, engineers, whatever, farmers. We're absent. As a nursing profession and as a nursing community, we're largely absent from forums where the decisions are actually made. We're not represented on boards, governing boards of hospitals or other nursing-driven organizations. There's way more doctors than nurses. Why?
Expensive.
It's expensive. What's expensive?
Getting a political campaign.
Well, sure, Shneyder for Senate. I'm starting to raise. It is expensive. It is expensive, but it's not necessarily that on a local level, right? And it starts at the grassroots. It starts at the local. That's where it starts. School boards, so forth. And it's certainly not expensive at all to start pushing toward your voice being heard on governing boards of organizations, community-based organizations, community health organizations. I'll give you the truth of it. We're complacent. We clock in, we clock out, and that's all we do. And we do a good job, right? Mostly when we're there with the patient in a moment. And then as soon as we hang up that hat, or whatever, hopefully no hats anymore. That's like the yesteryear. Remember when nurses were required to wear white hats? Like, what's that about? When I went to school, I had to do it. It was just something. It wasn't one of those, but it was more like a. And my hair wasn't getting in the way of anything, so I don't know. Anyway, so yes, we don't think ourselves as a profession that has a certain promise, right? Same, that question about, well, not everybody is practicing, not everybody who's licensed is practicing. I'm licensed. I'm licensed in California and then multi-state through Utah. Ask me when was the last time I actually practiced direct patient care. It was a very, very long time ago. And yet, I use this license all the time. I use the power that that license has all the time. But I also know my stuff. So anybody who is like, well, C is a passing grade, therefore, why am for 78 when 77 is passing? Think again. Think again. Nah, I just don't have time. Well, unsubscribe. Tell your Facebook friends, I will be MIA for the next, whatever, X years. And guess what? Ain't nobody gonna miss ya. Stop posting on Insta. It's a waste of time. Or scrolling through it. As a matter of fact, this, and then this, little doses of a certain neurotransmitter, a hormone, that constantly, dopamine, that constantly goes like, ooh, more, It is now compared, this, to a conditioned reflex in animals, pigeons. You can train a pigeon to click a thing for a piece of food. And constantly, and they keep them constantly sort of like half hungry. So they continue doing it. And then they're not hungry anymore. And they keep doing it. This attachment, this not being able to let go of it ever, because it's like security, oof. We've been trained, and we've been trained well. Just not on the right things. Consider that. So, know your stuff. Do not sort of like slide over something. If you don't quite understand something, We have help. Faculty are there, advisors are there, learner support services are there if there's something else comes up, but it's there. It's available to you. It is yours to use and succeed. Not only getting through school, but then getting licensed, getting into the job, and then actually becoming the most effective member of this profession that you can be. That's the goal. All right. So educate. What else? Yeah, and we've kind of talked about it. If you want, those things that actually can only be resolved politically, that's where the Congress comes in, right? And like state legislatures and local governments, city councils, so on and so forth. So consider. I love this next one. Population behavior and lifestyle. So inadequate health promotion, you already captured that. We have to educate around promoting health, preventing disease, and effective chronic conditions management, right? And yet it's so unsexy. Nobody's ever made a TV show about it. I mean, Mary the Grey is nowhere to be seen. With The Good Doctor, or whatever Chicago Med, like whatever is yours, because it's just, you know, it's just work that is not on its surface that exciting. However, the outcomes that work can produce, whoa, that is really exciting and fulfilling. Focus on that, right? Rather than some, you know, drip, 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 glamour. Poor nutrition, we've talked about that already, right? It is, and who gets the poorest nutrition?
The poor.
The poor! Absolutely. People living in poverty, people of low incomes, because there's only so much that can be afforded. Guess what? There are nutritious foods that are cheap. It's just nobody is educated that they're not poison. Like, for example, edamame. Exactly. Edamame, it's a bean that is sold out there, and probably every grocery store has it. They're frozen, you know, you can boil them. They're delicious, really, and very nutritious and very cheap, and yet, no. I want my meat. The best processed sausage that I can have. Anyway, so that lack of exercise, this device thing that I'm talking about is part of the issue here, right? So I'm not exaggerating when I'm inviting you to free yourself from it. It is very freeing to live without it. Yeah, and I have, and for whatever I give you a sort of a secret. We have people in our media and marketing that do that for me. They whatever. They're like, oh, Mikhail said something in the future of nursing. Oh, let's post it. I'm not. And then like it. Anyway, so again, it is consider it. Consider how much time you can have, and consider how much more movement perhaps you can have. I do use this for work and things like that. Another thing that I have on this thing, which is like the best gym membership that I have ever had, it's like $10 a month, and it's called Apple Fitness Plus. Not advertising that here, because there's plenty of different providers are available, and I never go to the gym, and I can do everything at home with a set of weights and a mat. And I get plenty of movement and exercise and all of that. Go for walks, really. Like outside is so great. And try not to fall. And preventable and poorly managed chronic conditions. That is one of the biggest issues that we're facing as well as a nation. And you've seen it from the data, and it's nothing is going to become better until you figure out. So like all your boring things like patho and it's like, oh, why it's so difficult. And, It helps with understanding how things are interconnected and what can be affected in order for the chain to start working in a different way. Our system itself built after the World War II. So the system that we have now. What was the biggest issues after the World War II? The biggest health issue. Babies. Babies was the issue. Baby boomers, ever heard that? The huge generation that only Zers now are surpassing in numbers, but huge baby boom. Men were out in the war, and women were there in the factories, producing whatever men needed out there. And then everybody comes back, and it's like, woo! Field day. I mean, everybody goes to work making babies. And there's a lot of babies were made back then. And so the system was partially built to accommodate, right? Because doing it the same old way with midwives or something like that wasn't real. I mean, it's like there's only so many. So we had to kind of make it more efficient. What else after World War II? What else? People were what back then as opposed to now? Skinny, yeah. So people were more active altogether. People had way more injuries because the OSHA at work wasn't quite a thing yet, and so people got injured at work. People got injured doing stuff that fun things and things like that. So we had to treat sort of acute episodes of things like that. Cancer wasn't as prevalent. Although the Madison Avenue made sure that anybody who wanted cancer could get it. So sexy. What else? So anyway, the system was built to treat acute problems and reactively, rather than actively, proactively promote health, prevent disease, and so forth. This thing of going back to the chronic conditions and nutritional choices and things like that. So cigarettes are not a good choice. Neither is Coca-Cola, despite its claims that it is happiness. No, the latest is magic or whatever it is now. It's like every couple of years they change it. They're like, Coca-Cola is community. I beg to differ, but the recipe is closely guarded because you shouldn't know what you're putting in your body, right? And then the prevalence of processed foods, the prevalence of processed drink, the prevalence of all of that stuff, that's what creates then these conditions that, again, they are preventable. A lot of this stuff is preventable. Cancer has been on a rise unimaginably in younger people. And all of this, and we wonder why. Why? Why is my body reacting in a certain way to the environment and to the things that I put into my body? Well, there's only so much it can take. So much abuse. Poor access and equity, we've discussed that. Financial sponsors. So you saw that $1.3 trillion comes from private employers. Right, so this is like the largest amount of healthcare sponsorship is sponsored through employer-driven health insurance. Now, employers, the vast majority of them, they just pay and pay and pay, and they're absolutely disengaged from actual trying to affect the outcome of what they're paying for. So Nightingale is one of the few that has, we invest a lot into wellness of our collaborators. A lot. We pay them money to become healthier, like for real. There's like, oh yeah, there's like a wellness app, we call it Wellevate, and people can collect points in there by sleeping better, by exercising and doing things like that, and then yeah, real money, right? Those, I don't know, Brienne, are you participating? Yes. All right, fantastic. Awesome. So there are things that employers, as a matter of fact, there's early 2000s or mid 2000s. Safeway, you know Safeway, it's a big a corporation, like grocery corporation and whatever, and they have like these offices, management offices, and not just management, but sort of like logistics offices and all of this in several parts of the country. And so they, some time ago, they kind of were onto it, and they're like, well, what can we do? And so cafeterias in their office places, people go for lunch and buy things. And they used to have like a burger and fries, $4, grilled chicken salad, $12. So everybody was just, was like, it's cheaper. I'm going to buy that and eat that. It will fill me up and I'll go. And then what they did, they swapped the prices. That's all they did. They swapped the price. They said, we're going to take a little bit of a loss on this grilled chicken salad, but we're going to make the burger essentially unaffordable. Guess what? A bunch of their people switched, and then they did surveys and so forth. Their behavior at home started changing as well, because they all of a sudden figured out that salad is not poison. Salad is good. Lettuce, yay! So little by little, plus children of those employees as well, right? They started getting used to something that is better for them rather than. So there's many different strategies as to how to address these things. Inability to access care, cost and provider shortages. You are charged hereby to becoming a registered nurse or PN out there, if anybody of you are in the PN program, and contributing you to the solution to solving the shortage. Try not. It is tough, but one thing that I know about all of you, because we checked it, you absolutely are capable of doing it and becoming a nurse. It's up to you though. Like I can't, I wish I was Oprah. I'm like, a license for you and license for you and yes, I know. But I'm not, so you got to do the work. You got to do the work. We can offer resources. We can provide facilitation for you. We can do all of that. We cannot take those steps for you. You have to do them yourself. Yes?
Wellness app to us learners
The wellness, yes. I preview. It's coming. Something that's called Wellness Pursuit is coming. We probably won't pay you. But, we pay our collaborators because we're not paying for your health insurance. But it's definitely, and we're incorporating the Wellness Pursuit, it's called, and it's in piloting stages now, into the curriculum to address to provide resources and help you address all of the 8 dimensions of wellness: physical, emotional, mental, occupational, so on and so forth. So that's coming. I'm very excited about that, and it will be threaded throughout the program, and you guys are already in, so you'll get sort of like later, but you will be getting that. So that's totally absolutely coming.
Will they have quick, easy recipes on it?
Probably quick, easy recipes on and sort of links to different sources. And I haven't seen it, but it's sort of like it is like that Trivial Pursuit game but you collect badges and you learn things and sort of you apply things, and then it's a game, yay. It's awesome. But yeah, that's a great suggestion. I keep doing this, right? You think one would learn that that's not working. Okay. Okay, let's talk about high spending. And again, sort of what it is that you can do to address any of it. That first one, pay per service. What does it mean versus performance? That's how our system is set up. Yes?
They're just paying just to go to the doctor, even if they don't really need to be going.
Right. So the system is set up to incentivize volume. Right? Volume of stuff that is done. Hence unnecessary diagnostics, hence unnecessary prescriptions, hence unnecessary things, and we stumped, and we're like, oh yeah, those poor people in Canada, they they have to wait 3 weeks or 4 weeks or 2 months for something. Because it's okay. It is not immediately needed. Yet again, if you're my mom, right, remember? Now! Or all those commercials, ask your doctor if so-and-so is right for you. Sort of like a match game, right? It's like you're meeting a spouse, so they're right for you. And the system pays and pays and pays and pays and pays and pays and pays for all of these services, a bunch of which are unnecessary, rather than paying for actual outcome, right? So the payment for outcome, for example, if you're a hospital and we're paying you for whatever it may be, somebody shows up with, exacerbation of their chronic heart condition, and they're there, and they're maybe in ICU, they're somewhere else, and we're paying and paying and paying for you to get them better. Now, if guess what? If they get an infection while they're in your hospital, yeah, we're not going to pay you for that. Because that's not a desired outcome that was there with this hospitalization. So that's the difference. And think about that. Overprescribing, I just said that, right? It is again, we're the only country where pharmaceuticals are advertised widely on television and everywhere else. And of course, we're so good at self-diagnosis and kind of knowing exactly what we need at the time. Because yes, I want to feel that way. Yes, I want to twirl in the hills. Yes, all of this. Prescription number 1, cut the cord. Cut the social media cord. You will feel so much better. Turn off TV every once in a while. You will feel so much better. Now, unnecessary diagnostics, lack of care coordination, remember that? It's like, oh, this hurts. So I think I'm going to go to specially covered people, that can go anywhere. It's $25. Why not? I'm going to go to pulmonologist just in case. Just to make sure that, this pain is not coming from my lungs. Yeah. Constant. It's constant. Right? Self-directed sort of, and this is we as a consumers of healthcare. That's what's, there's nothing better. That's really there. I mean, primary care, is in play. It's and some insurance makes you go to primary care at first but they don't have much time with you. So it's that lack of care coordination, continuity, litigious. We're litigious, right? I don't think my mom has done it, but people do. They show up at the doctor and it's like, prescribe this or else. And they don't have time. And they want to. Administrative costs, we talked about numerous payers coordinated with numerous providers. Billing and paperwork is endless. Remember that $300 billion almost annually? That's there. This next one, I've described in quite a detail, shortages, and then consumers. Consumers. themselves, right? I want it, and I want it now. That's the behavior that we have now. And I don't care what it costs if I'm covered. Because to me, it only costs $10. I don't care what the system pays for it. It's only $10. Now, and there's quite a bit of pricing difference. Quite a bit of pricing difference between different providers and for the same service with the same outcome. You can pay triple, quadruple the price, and not you really if you cover it. It's the insurance will pay means the system pays and everything becomes even more expensive. So now, ever shopped on Amazon? Yeah, if something is 17 cents cheaper, guess what? I'm buying it from them. Somebody sells that same thing. 1 cent. 0.98 versus 0.99. Why spend? We don't have at all that mindset when it comes to healthcare. And spending. And not spending the consumer's money, but spending the system money, taxpayers' money, so on and so forth. So overly optimistic, I talked about that. Oh, that's not going to happen to me. That's for them. That's for the others. I am really going to avoid that because I feel good about myself. All right. Time will certainly show. Lack of effective health education, back to what you said, and sedentary lifestyle. You know, I made you sit here for like 2.5 hours, right? Yeah, and that's what it is nowadays. We sit and 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 we forgot. And in order to actually to get moving, you got to get out and do it. All right, so I have about 15 minutes or so to talk. Now it's all yours' turn to actually now tell me about things. Let me see. Oh, hold on. Before we go, I'm going to check whether I've shared all of the data that I was going to share with you. Oh, yeah, no, I didn't talk about this. This is an important thing. So, the one thing that we haven't touched upon is maternal and infant death that happens in this country. So currently the U.S. maternal mortality rate is more than tripled what it was 35 years ago. All of the progress, all of the tech, all of the everything. Sorry, all of the progression in medicine, triple. In 2020, there were almost 24 deaths per 100,000 births, or 861 deaths total. Now, with maternal mortality, just so you have a perspective, we're not even in that top 13. That was, or 12, that was on my slides, on my comparative slides. We rank in somewhere in the 40 place something in the world. After the republics of former Soviet Union, like Turkmenistan and Kazakhstan, and so we rank worse than some developing countries. Now, check this out. Among black people, 55 per 100,000. 55. The rate that is unseen, really, anywhere else in the developed world. And it's almost triple that of white people. Pregnancy-related death per 100,000 climbed from 44 in 2019 to 55 in 2020. among black people and from 13 to 18 among Hispanics. So why? Why 2020? COVID, yes. So that contributed quite a bit. The overburdened system that got even more overburdened, and certainly we were not prepared for that system, and certainly that burnout that you talked about happened. Right? People said no. I'm going. I'm not putting my life in jeopardy any longer, and so you have quite a bit of that. So the system that were already strained got even more strained, and then the effects of it you'll see right away. By the way, the spending, the $4.5 trillion, has come down in 2022 from the previous 2 years. Yes.
The numbers of people who, when COVID hit, just left the profession.
I don't have that number. I'm sure there's estimates. It's really difficult to kind of pinpoint because this data, we don't collect essentially data anywhere centrally, and some states do kind of like nursing workforce surveys, some states don't, so it's difficult to pinpoint. But again, from anecdotally, the numbers were quite astounding. And then another thing that happened is that many nurses shifted from kind of working for an institution to going to like travel nursing and making triple and working in the same institution. So that has happened, right? So because people saw an opportunity, and like you can't blame people, but guess what? The only thing that could have prevented that. Having enough nurses, having enough supply, right? That in the nation, and it's the travel. So the travel spend is declining, it's going down, but it still is a significant portion of and many. So you there are stories out there constantly that hospitals are closing, healthcare facilities are closing because they cannot afford to stay open anymore, right? So that's and then again, and that's the vicious cycle that continues going and going and going and going because of actually in rural communities, this is a fact. In a rural community, if it has a critical access hospital, if a hospital closes, the whole community dies out essentially, right? People move away. Because the hospital closing, then the pharmacy closes, then like little by little, just the bank leaves, the local bank and so forth. So it is, healthcare is and should be kind of the backbone of all of the communities. And when when there's nobody to staff, it really affects. And the education system, nursing education system, is designed in a way that it's concentrated, right? Like it's only in certain, it's like we don't have people living in rural communities. We do, and like there's no needs, healthcare needs in rural communities. There are.
They are,
but yeah.
sometimes scary.
Well, scary, not scary. If you grew up in the community and you're part of the community and you want to be a nurse, right? What do you have to do? You have to move away. And then after you move to Vegas, baby, who wants to go back? To, I don't know, like I'll pick on Wendover or something, or Elko. So, yeah, you're right. Okay. So that's just a statistic, and just to highlight the inequities that do exist in the United States, and these are very complex issues. They're a very complex problem. Many of them do require systemic solutions or legislative solutions or regulatory solutions. Many of them, though, it requires grassroots awareness, your involvement in building all of this. At the end of the day, what you do and how you go from here on out, what you learn, how well you do that, how you use it in your now and in your practice really, really matters. And it can really, really, really make a difference. You know, this song and dance that I do, like going around the country and speaking with the learners, and we broadcast it, that's for a reason. I don't know any other nursing educational institution in the United States that actually does this, that actually does what we do. So the opportunity is there. Stay resilient, and you will be that future, the future that all of us need, and certainly all of us deserve. So I'm so excited for you. I was like, I'm kind of like, you know, this is what I decided to do, and sort of, okay, you know, I don't know. Political office is next, likely, you know. but you all have like incredible paths that you can take in sort of chipping away from this. Am I like Mikhail and Nightingale, we're going to solve it all? No, absolutely not. But are we contributing in the right direction? Absolutely yes. So, and that's what matters. Better matters, right? Inching the outcomes forward, bending the unsustainable paths of today, both in spending and the poor outcomes. It is no longer sustainable. It cannot continue the way it is. And again, we, as nurses, we have an incredible power if only we individually decided to harness it and then band together and drive real change into the system. And real change in the system is absolutely needed. It's absolutely a must. So it's yours. It's in your hands. I'm looking at all of you, and I cannot see you all out there, but it is definitely in your hands. Without you, I don't know. There's nowhere to move. So it absolutely needed. All right. So that's that. I'm going to take sort of last thoughts, comments.
What type of nurse were you on the floor?
Well, okay, very good. What type of nurse I was? So the vast majority of my direct patient care was in nephrology and dialysis. So I did nephrology both in acute setting and dialysis in chronic settings, and then I've managed dialysis clinics, and then when I didn't see, what I noticed, and this is a great actually question. So what I noticed in my practice, even as a just floor nurse, is that I would show up and I would be all like, let's do this! These patients can be so much better because of us. And people are like, clock in, clock out, sort of do whatever. And then, so this is how my management career actually started. I went to the clinic director at the time, and I was like, okay, make me a supervisor, and we'll improve the outcomes, on my shift at least. And like, I wore her down. Yeah, I was like, I went like a few months, and then finally she was like, okay, fine. And I said this too, you don't even have to pay me anymore. I just want, oh yeah. As a matter of fact, my management jobs and progressing in management, for the first year of every job, I said, I'm not going to ask for any more salary. I am going to do what I'm passionate about. I'm going to try building what it is, and after you see the outcomes, then we can talk money.
And did that happen?
It absolutely. Do you see me standing here as a CEO of a pretty successful enterprise? Yeah, so it happened, but it wasn't any different when I first started the job. So and yet again, right? So this is just reframing. This is a different approach to how you look at things, right? Should I delay? Because normally we're like, no, give me more money, then I'll do more. And I just looked at it differently, and so, yeah. So absolutely, from a immigrant, refugee escaping ethnic persecution in my homeland, and again, not speaking any English, not having any money, having whatever, to now that's, So I know resiliency, if any of you, and look, if this guy could do it, and push through and survive and do all of that, you all can do it. It is absolutely possible. You, through driving yourself to become better, to learn, to push, you can totally make your communities better, and you can, and by extension, the world a better place. I mean, and at the end of the day, this is what I'm after, right? The flourishing of everybody. I'll finish with this. It was March of 2020, so 23 years ago. San Francisco, sunny day. Oh, 2020, 2000, sorry. See, a little dyslexia doesn't hold me back. So 2000, year 2000, March of 2000, so 24 years ago, pretty much. And San Francisco, sunny day. I find myself standing in this auditorium. It's called the San Francisco Masonic Auditorium, and a bunch of people, all different people, all sorts of all colors of the rainbow. Like everybody's there, and everybody's exciting, and the buzz and the energy in the air is just amazing. And there's this guy in judge's robes, and he's a judge presiding over the whole thing on the stage. And then at a certain point during the ceremony, he invites everybody who is there for this one specific reason to stand up and recite after him. And that recital goes like, I pledge the allegiance to the flag of the United States of America and the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Those words, and becoming the US citizens, that was one of the most consequential days of my life. And taking that pledge, it wasn't just the words. By golly, I was going to figure out how to do that, how to make my contribution to one nation, indivisible, where liberty and justice is accessible to all. So, and this is part of this never-ending quest of my life. So I thank you for coming here. I thank you for dialing in from over there. I hope this was useful to you. I hope you can take this and make some commitments today to your studies, and then to making the system better, and to the populations that you will serve. Thank you so much. Flame forward, everybody. Thank you. See you all out there.